Pleased to have Dr. Bethany Foster from McGill University presenting the webinar. Dr. Foster is part of the CNTRP Project 6, and she's a pediatric nephrologist and a clinical epidemiologist at McGill University, where she's also an associate professor of pediatrics. Research-wise, she's primarily interested in the long-term outcomes of children and young adults with kidney transplants, and so she looks at adolescent and young adult kidney transplant recipients who've been identified as being especially high risk of graft loss, where graft loss in this population is often due to poor adherence to the immunosuppressive medication, and it's related to the developmental stage they're in, and also is affected by the process of transferring from pediatric care to adult-oriented care. Dr. Foster has led a very successful multi-center randomized trial of an intervention to improve medication adherence among 11 to 24-year-old kidney transplant recipients, and is now leading a follow-up study to adapt the intervention for the use in clinical practice. These studies were both funded by the United States National Institutes of Health, and she's also heading a Canadian national cohort study to identify care processes and structures that promote better adherence.
So I'm going to be talking to you about medication adherence in transplant recipients today, and although I focus on kidney, I'm hoping to talk more broadly about all solid organ transplant recipients. So the objectives of my talk are first just to define adherence and describe its different components. Then I'm going to review some of the determinants of adherence and describe a helpful framework to identify these determinants. Spend a little bit of time considering the different ways of measuring adherence in both clinical and research settings. And then I'll consider different intervention strategies to try to improve medication adherence in this population. So just to start with the basic definition, I think most people understand what we're talking about, but adherence is defined as the extent to which an individual's behavior coincides with medical or health advice. And what we're really looking for is satisfactory adherence, defined as sufficient concordance between the prescribed treatment plan and the patient's behavior, such that the outcome is unaffected by any deviations from the plan. Unfortunately, in transplant, we really don't know how far someone needs to deviate from their prescribed treatment regimen in order to get adverse outcomes. And there actually are some data to suggest that even fairly minor deviations from the plan can result in rejections and potentially graft losses as a result. And so we're really aiming for really excellent adherence in organ transplantation. I like this quote from Tolstoy because I think it applies to adherence as well. So I would say all adherent patients resemble one another, but each non-adherent patient is non-adherent in his or her own special and unique way. So why is that? Well, there are a few different components to adherence. Adherence can be divided into two broad categories, which are persistence and implementation or execution. So persistence is really that you carry on taking the medication that you were prescribed or doing the health behavior that you were recommended to do. And the problem with that would be just discontinuing it. So that doesn't happen so often in organ transplantation, although it does happen that people just stop taking one or all of their medications altogether. More common problems are problems of implementation or execution of the plan. And these can be divided further into problems with taking the medication, which could be missing doses either intermittently or consistently, or could even be a drug holiday, which is when the patient misses a number of consecutive doses. There could be, so that's reasonably common, both drug holidays and intermittently missing doses. Problems with timing of the doses as well is very common, probably the most common problem, where doses are taken off schedule either intermittently or consistently. More difficult to detect are errors in or problems with dosing of the medication. So problems with dosing can be either errors in dosing where the patient inadvertently takes the wrong dose. This can happen either because there's a miscommunication with the pharmacy and they supply the wrong dose, or the patient gets the right medication but takes the wrong dose. And those kind of little errors are usually picked up fairly quickly if the clinical team is reviewing or the pharmacist reviewing medication doses with the patient, but not always. The harder to pick up is deliberate under or overdosing, and this is probably more common than we realize. Frequently, patients who have financial difficulties in purchasing all their medications may reduce the dose to try to stretch the medication longer so they don't have to buy as many prescriptions. Also possible is a patient who has taken a drug holiday or missed a few doses and is coming up to a clinic visit where they know they'll have their drug levels measured, and so they take a bunch of medication ahead of the visit to try to make up for lost time, so to speak. These kind of things are much harder to pick up. Adherence is not stable necessarily over time. So there have been a couple of studies looking at changes in adherence over time, and more studies and more data looking at people at different points post-transplant to see how adherence differs. Certainly it's been observed that adherence is typically very good in the early post-transplant period, but that it wanes over time. It's also important to recognize that adherence may fluctuate with different life circumstances, may change with developmental stage, and that most patients are going to have some time in their life where adherence is difficult for them. Also important to recognize that the type of non-adherence that people are experiencing may also change over time. So they may have some difficulty with taking, then move to having difficulty with timing, and perhaps get better, and then at another point in their life may have dosing problems. This is one nice example of a study from Sabine de Geest's group in Switzerland, where they actually followed patients over 3 years from the pre-transplant period to 3 years post-transplant and measured medication adherence using a self-report tool at each of the time points noted on this graph. So along the y-axis, we have the percentage of patients who were identified as non-adherent, and I can't remember exactly what their definition was. I think it was more than or less than 80% adherence, but I'm not entirely sure. In any case, the gray bar is all different organ groups combined. The then the organ groups are split out with different lines, so liver, heart, kidney. Obviously, the greatest proportion of patients are kidney, which is why kidney follows the gray line better, and then lung in the dotted lines. So you can see that in the pre-transplant period, the kidney group had the highest rates of non-adherence of any of the organ types, but that all organ groups had quite low levels of non-adherence at the 0.6 months post-transplant, and then all also sort of increased gradually in the time following transplant, with liver having the highest rates of non-adherence of all of these groups, at least in this study. So this is kind of what we expect to see, with really good adherence in the first months and then some sort of slippage over time. In the pediatric and adolescent population, there are other factors also playing a role. So as adolescents and young adults become increasingly independent from their family, they have more opportunities, I guess I would say, to be non-adherent than younger children whose parents generally take care of all of that for them. So there have been a variety of different studies showing that adolescents have much higher rates of non-adherence than younger children, or than a pediatric population that included both younger children and adolescents. So almost 2 times higher rate in this study. In a meta-analysis of solid organ transplant recipients, so not just kidney, the other one was kidney, they actually found a 3 times higher risk of non-adherence in adolescents compared with younger children. There are very few studies that have actually, and I would say no good studies, that have compared adolescents and young adults to older adults. So this table below here is from a study published in AJT in 2009, where they used medication possession ratio data, which comes from administrative records of payment from pharmacies for patients in the United States on Medicare, to try to get an idea of their medication adherence. And in this study, they found that the 2 youngest age groups had a higher proportion with poor adherence and a lower proportion with excellent adherence compared to the older age groups. So some evidence perhaps that these groups are less adherent. However, these are all patients that are covered by Medicare, and whereas the vast majority of individuals, for example, over the age of 65, and even adults in the sort of middle age range here in the United States are frequently, if not all, on Medicare, in the younger age groups, the vast majority of these individuals are covered either under their parents' insurance, private insurance, or by other means, and so the patients that are represented here are probably a very biased subset of patients with a lower socioeconomic status, and so it's not clear how true this really is. So why do we care about poor adherence? Well, I don't think this audience really needs a whole lot about that. People, I think, are believing more and more that poor medication adherence may be the most important mediator of late acute rejection and graft failure that we see today. Chronic poor adherence can lead to donor-specific antibody formation and to antibody-mediated rejection, which is one of the most important reasons for late graft failure. A prior study showed that among pediatric recipients, each 10% decrement in adherence was associated with an 8% higher risk of graft loss. And studies, this is a study from the Winnipeg group of Chris Wiebe, including both adult and a small number of pediatric recipients, that compared de novo donor-specific antibody development over time in non-adherent versus adherent patients, and you can see how big the difference is. Now, this is probably a little bit exaggerated because of the way they captured adherence, but I'm sure there is still some validity to this, and that the differences are large. This graph comes from a USRDS study we did a number of years ago. We were looking at age-specific graft failure rates. So on the y-axis, we have the rate of graft failure per 100 person-years of observation, and on the x-axis, the observed age. So what you're seeing here is graft failure rates among 6-year-olds, 7-year-olds, 8-year-olds, and so on. I think it's fairly evident that the graft failure rates are stable in this early childhood period, increasing from about 10 or 11 years of age and peaking in the interval between 17 and 24 years of age, decreasing thereafter, and then fairly stable. This study only went out to 40 years of age. When we did multivariable analysis, adjusting for all potential confounders as well as time post-transplant, the pattern we saw was, so the reference group here is 20 to 24 years old. All the other groups except for the 17 to 20-year-olds, which were basically the same as the 21 to 24-year-olds, had significantly lower risks of graft failure. So this was in kidney transplant. We did the same thing in heart transplant, and again found the highest risk of graft failure between 17 and about 29 years of age for heart transplant recipients. The definition of graft failure for heart was a little bit different than for kidney. So for kidney, the definition was retransplant or return to dialysis, whereas the definition for heart was retransplant or death due to graft failure. So that may explain why the upper end of the age range of high risk is a little bit longer, because they had to wait until there was death. But again, the very same sort of pattern we're seeing here. And in liver transplant recipients who had a similar definition of graft failure to heart, again, a very similar pattern, peaking in the early adult years. So why do these adolescents and young adults lose their grafts more? Well, we think it's probably at least in part related to poor adherence in this age interval, since they're becoming more independent and having more opportunities to be more adherent since their parents have handed over the responsibility of medication adherence to them. So certainly there are reasons at the level of the patient that are playing an important role. But there may be other factors as well. And I think that the framework that Bourbon put forward some years ago, considering different levels that can influence medication adherence, is a useful way to think about it. So this diagram here is useful, but I like the levels that Bourbon put forward a little bit better. So we're going to go through these different levels, which she characterized as patient level, micro level, meso level, and macro level. So we'll go through them one by one. So at the patient level, these are just things about the patient and about their condition that may predispose them to non-adherence. So this includes things like socio-demographic factors, individual level factors like health beliefs and self-efficacy, perhaps knowledge about their condition, condition-related factors such as the nature of the condition being treated, so transplantation versus diabetes versus hypertension or other things, whether they have important comorbidities, particularly psychiatric conditions, and then treatment-related factors like side effects of the treatment or complexity of the regimen. The micro level is where the patient is interacting with their environment. So they're either interacting with their own social environment, such as their family, their friends and social supports, economic factors in their life, but also their interactions with the care team. So this would include things like quality of the interactions with the care team. Do they trust their care providers and believe what they're saying? The next level, called the meso level, has to do with the way care is organized and delivered and who is involved in doing these things. So it could include things like accessibility to care and to the care providers, the expertise of the individuals on the team and who is on the team, what kinds of professionals are there supporting them, as well as the care processes. So how often are they seen in clinic? How frequently do they have blood or other monitoring done? And then finally, the highest level is really healthcare systems related factors. So things like how is medication insured and care insured and covered, and also the general culture of the care. So that an example of that would be pediatric versus adult-oriented care. The culture is quite different in those two settings, and that may have an impact on adherence as well. And that's some of the, we're looking at some of those things in Project 6 and the CNTRP, as well as meso-level factors, in fact. So now we're going to move on to talking about different ways of measuring medication adherence. Measuring medication adherence can be divided into two broad categories, direct measures and indirect measures. And I think it's important to acknowledge that there really is no gold standard way of measuring adherence. Everything has significant limitations. Some are better than others. So the only really direct measure we have of adherence, aside from watching people take their medication, which is really not very feasible to do outside a hospital setting, is serum drug levels, which I'll speak a little bit about in a moment. And then we have a variety of indirect measures. So we have self-report measures, collateral report, which is having a family member or a member of the clinical team give their opinion about the patient's adherence or non-adherence. We can use pharmacy records, and then finally electronic monitoring. So Some combination or all of these can be used in clinical care, but electronic monitoring so far has really been mainly used in the research setting. So most people may have heard about using variability in tacrolimus trough levels to assess medication adherence, and the hypothesis is that if you have a large amount of variability in the tacrolimus trough levels within a patient, this might represent erratic drug taking. So it's been proposed that you can calculate a standard deviation of the tacrolimus trough levels that a patient has done for usual clinical care to get an idea of their medication adherence. And certainly there have been a number of studies showing that standard deviation of tacrolimus trough levels correlate with important outcomes. So in liver transplant, they were shown to correlate with liver enzyme levels as well as with biopsy-proven acute rejections. And in a study out of Toronto among young heart, liver, kidney, and lung transplant recipients, they found that each 1 unit higher standard deviation of tacro trough levels was associated with a 58% higher risk of graft loss. And there are other examples as well showing a good correlation between tacro standard deviation and outcomes. However, there are other factors that also are associated with variability in tacrolimus trough levels. So, for example, if a patient takes their drugs with food sometimes and without food other times, that may affect the trough levels and increase the standard deviation. So it may not only be measuring adherence. Variability in tacrolimus trough levels almost certainly captures non-adherence in some way, but there may be other factors that are playing into it. Interactions of tacrolimus with other medications that they may be taking may also affect the pharmacodynamics of the medication, the pharmacokinetics, and cause variability in the levels. And so recently there was a trial that came out just in December of this year where they used an intervention, and I'll show one of the graphs from that study in a bit. And they found that the intervention improved electronically monitored adherence, but not variability in tacro trough levels. And so it begs the question, is variability in tacro trough levels really measuring only adherence, or is it measuring other things that are also important to outcomes? The other limitation of tacrolimus trough levels is that you need at least 3 levels to calculate a valid standard deviation. And so it's going to depend how frequently blood levels are done, whether you can actually calculate the standard deviation. So for people who have monthly blood levels, you need at least 3 months worth of data to be able to even calculate a standard deviation. For people who have levels done less frequently, you need even longer intervals. And so the clinical applicability of this is somewhat questionable if you need very long levels. Of course, you also have the problem of some of the most non-adherent patients may not turn up for their blood tests and therefore will not have enough data to allow you to calculate levels. So this is a way of measuring adherence that has gotten a lot of press, that may be useful but has some significant limitations. Self-report is one of the most commonly used ways of measuring non-adherence. It's been repeatedly demonstrated to underestimate non-adherence. People tend to be quite optimistic in their self-reporting of their adherence. There are a variety of tools available, that use these techniques to try to improve the quality of the data that's collected. So some of the techniques that can be used are to normalize non-adherence. So instead of asking if they ever miss, you ask how often they miss, sort of giving them license that this happens to everybody. It's also useful to provide a time interval anchor for them to ask in the last 2 weeks or in the last month to try to help them with that. Sometimes it's useful to sort of reconstruct verbally situations when doses may have been late, so asking them to go through their day and when they might have missed. Some have suggested that corroborating with a parent or nurse or physician report may be helpful, although correlations amongst these groups on self-report are actually not that great. Most of the tools that are available for self-report ask about the number of missed doses and or about the number of late doses within a specific time frame. The benefits of a shorter time frame are that you'll get better recall. But the disadvantage is that in a very short time frame there may have been no non-adherence, and so you may not capture very much. With a longer time frame, of course, you're going to capture more, but trade off on their ability to recall. So there's a few different tools available. One that I have some experience with is the McGill adherence measure, which is asking for non-adherence in a 1-week time frame, which is actually quite short. It's designed for children and adolescents, but the short time frame results in very high adherence since you're not necessarily capturing all the events. Another good tool is the BAASIS assessment of adherence with immunosuppressive medications. It was designed for adults, but it's actually quite similar to the one that was designed for children, and has the nice feature of having a 4-week recall time frame, which allows capture of more events, and also has this nice visual analog scale, and it's quite easy to use. There are other tools also available. Pharmacy records can also be used, although they have a lot of limitations. Pharmacy records can be used to determine if the patient has adequate supplies of a medication available in a given time interval. It can be useful, and I think many of us have used it in the clinic from time to time. We'll call the patient's pharmacy to see when they last were there to pick up their doses and how often they've been there. However, if the patient is using multiple pharmacies, this won't work very well, and it can also be complicated by patients with stockpiles of medications because of frequent dose changes. So it may look like they're not taking their medication, but in fact they may have quite a lot of excess medication at home that they have at their disposal that's not sort of being counted in that. Another limitation of pharmacy records is that it provides only summary information for an interval of time. So you know that they had enough or not enough medication in a month, but you really can't say during that month when something went wrong. And of course, there's no information at all on whether their doses were taken on time. Electronic monitoring is gaining popularity, and I think probably within the next 10 years we may start to see it actually used in clinical practice as technology advances. There's two sort of broad categories of devices available. One is the single bottle devices. The most common and most well known is probably the MEMS device, which is on the right here. So basically it's an electronic chip in the cap of the bottle that records a date time stamp every time the cap is opened. Similar device is the Vitality Glow Caps device, which also has a chip in the cap, and each bottle only stores a single medication dose. So these have been used in a lot of research studies. These are newer, so they haven't been used in as many, but they're starting to come out, studies using this device. And then there are multi-dose pill boxes. So these are pill boxes that you can either slide a multi-dose blister pack into or fill into the individual cells. And again, when a compartment is opened, it records a date time stamp on the time that the compartment is opened. The nice thing about the more modern technology, this type and now MEMS and glow caps as well, they allow you to put onto a patient's personalized website the times that their doses are due, and then the patient can choose to get text message reminders to remind them to take their medication if they don't take it out on time. So that's a really nice feature of these devices. Of course, Electronic monitoring is not perfect either. They have to want to use it, and they have to actually consume the pill after they open the device. So one of the major limitations of electronic monitoring is all they have to do is open the cap or open the compartment, and it gets registered as them having taken the medication. But we can't confirm, of course, that they actually did take the medication. A really nice feature of electronic monitoring is it gives you a huge amount of data. So unlike pharmacy records that just give a summary, electronic monitoring gives you a data point every single time they open that device. So for a patient on BID medications, you have 2 data points per day of observation, which is a heck of a lot of data, which you can do a lot of kind of cool things with. So this allows you to look at changes in adherence over time in individual patients, to allow you to, it allows you to identify groups of patients that have the same pattern of medication taking. So this graph just shows an example of a trajectory analysis that you can do with this kind of data. And Julie Boucamel, who I think is on this call, I saw her name, is doing some of this kind of analysis with the data we're getting out of our studies. So this example is actually, I think, children with epilepsy. And with the electronic data and using latent class analysis, you're actually able to pull out different patterns of medication adherence taking. So this group, for example, had really fantastic adherence and stayed pretty good over time. This one, pretty good adherence but slight decreasing. This one sort of moderate, and then there were these 2 groups that just kind of started, there's the started strong and then did badly, and the started weak and just completely stopped. So this is the kind of richness of the data you can get out of electronic monitoring. Of course, you can also look at timing of doses and how late or early they might take them. You can look at day of the week. There's almost no end to the stuff you can look at using electronic monitoring. Okay, so now I'm going to move on to talking about ways of improving medication adherence. And I think you can think about it sort of on levels, just the way we thought about the determinants of non-adherence. So we can think about making interventions at the programmatic level. So programs are applied to everyone in the transplant program with the goal of really lifting up everybody's adherence in the entire group. We can do systematically targeted interventions where we have a system in place to identify high-risk patients and then intervene only on those who are determined to be at high risk. And then the technique that I think most people use in their clinics these days is sort of ad hoc, right? They find a patient who they think is non-adherent and then jump all over them with everything they can think of. So I think in the future, I hope that we're going to be able to develop proven and effective interventions that target all of these levels. So for example, at the programmatic approach, we could think about the way we organize our clinic, the hours of the clinic, how often the clinic is run, and how that may support better adherence. The people who are staffing our clinic that may support better adherence. We need to think about monitoring adherence, whether that just be using a self-report tool and asking about adherence at every visit, whether that be evaluating variability in Tacrolimus trough levels, or both of these things, and perhaps in the future also electronic monitoring. We can routinely try to simplify the medication regimens for all the patients in our clinics to try to improve their adherence. And also, we need to think about preemptive intervention, and this can be thought of sort of as anticipatory guidance. So you have a 10-year-old, you know they're going to become an adolescent, you know that they're likely to have poor adherence as they take more responsibilities. We can start early to try to prevent that. Similarly, with adolescent and young adult patients, we know from experience with other patients of that age when they tend to get into trouble. So a lot of teens will say, well, I was out with my friends and I didn't have my medication with me and I didn't really want to just leave, so I missed my dose. So you can talk to them about when those things are happening and what they can do to prevent them. Just make sure you always have a dose of your medication in your pocket. Those are things we can do with every patient in our clinics. In order to find patients who are at particularly high risk, we need to monitor them and we need to assess them pre-transplant. And a recent study in the U.S. found that very few centers were actually formally assessing adherence in their transplant patients pre-transplant, and of those that were, the vast majority, like 95%, were not using any formal tool. They were just doing sort of an informal assessment of adherence, which is certainly better than nothing, but it is probably useful to assess adherence pre-transplant so you know who's high risk and perhaps to prepare them better going into their transplant. Another way that has been used by a limited number of groups is to intensively monitor non-adherence with electronic monitoring for a brief period post-transplant to identify those people who are already displaying high-risk behaviors and intervene in those people. And intervention in the high-risk group really needs to be done in a structured way. There's still a place for ad hoc, sort of individual level intervention. There will be some patients who have such significant barriers to adherence that they may require either family intervention or individual psychological intervention. So this would really include people who are either have health beliefs that prevent them from taking their medications as prescribed, or in the case of adolescents, may do this on purpose. Fortunately, that's not a large group, but there are people like that who really need more intensive intervention. So what are the barriers to adherence? It's important to think about what the barriers are in trying to design appropriate interventions. So if we're going to design interventions, we want to design interventions that tackle the most common adherence barriers, as well as personal barriers that people have. So the most commonly identified barriers were, in a couple of studies that were done, were forgetting and poor planning or scheduling problems. And I would say those probably kind of fall in together, that forgetting really means that they weren't organized enough to remember. Fortunately, as I mentioned, voluntary resistance or attempting to be normal, so not taking the medications, is less than 5%. Similarly, things like medication side effects or taste, difficulty swallowing them is not especially common. These numbers relate to children and adolescents. Financial barriers are probably more important than we think. A survey in the United States found that 87% of adult programs and 67% of pediatric programs indicated that patients frequently express concerns about costs, and also large numbers indicated that more than 20% of their patients had trouble paying for their medications. And I'm not sure that's so different in Canada. So if we're thinking about putting together an intervention, the factors we need to consider are education about adherence and medication, whether we want to feedback adherence data, using a multi-dose pill box or other organizational tools that may help people, using dose reminders. Family and peer support have been shown to be helpful in some cases. The use of a coach or a personal trainer has been shown to be helpful in diabetes and some other conditions, such as HIV. Problem-solving skills training can be useful, as can motivational interviewing. So which interventions are effective? Certainly, I think we know by now that interventions that include education alone don't really work. You need education plus something else to get some benefit. Packaging interventions like multi-dose pill box or multi-dose blister packs appear to have a positive effect on adherence in chronic illness. This is not specific to transplant. A meta-analysis of randomized trials in which adherence was assessed by electronic monitoring found that feedback of a recent dosing history captured by electronic monitoring was very effective and was identified as possibly one of the most powerful interventions that can be made to improve medication adherence. This graph comes from the study I mentioned earlier, so this was published in AJKD in December of 2016. This was a relatively small trial with 3 arms. All patients were using the Vitality Glow Caps bottle device, which in the control group they just used the device to monitor their adherence and got no reminders and no other intervention. The blue line is people who were able to get text message and I think email maybe, reminders as well. And the red line is people who got reminders and also knew that if they missed their medication, their transplant physician and their transplant nurse were being notified of it. They didn't necessarily have to do anything about it. They were just being notified. So you can see that everybody's adherence went up initially when they started the intervention, although the intervention groups had a greater increase. They stayed pretty stable, but over time then the patients without the notifications started to sort of fall off, whereas those with the notifications had significantly better adherence. So this is a nice example of how electronic monitoring can be potentially used to improve medication adherence. And it was in this study where they found these significant differences in the intervention groups compared to control in electronically monitored adherence, but no difference in Tacrolimus standard deviation levels. So if we want to improve adherence, I think we have to intervene at multiple levels, not just at the level of the patient. We need to take a multifaceted approach. Any intervention we deliver has probably got to be delivered at regular intervals, so it won't be good enough just to do a 3-week intervention and then hope that it's going to stick forever. People are going to need to be boosted and to be intervened upon regularly. Probably the most successful interventions are going to be individually tailored and personalized to address their own barriers, as well as generally addressing common barriers. We need to anticipate that adherence may change over time, particularly in young people, and be proactive about this. We can't expect them to be perfect, and we need to allow time for change to happen. So I'm going to stop there and just acknowledge my funders, the CNTRP, and my collaborators, and I will take any questions.